Okay, everyone, we have two more segments we're going to present for you here today before we wrap things up. We certainly have to be mindful of behavior in all this. We heard a great story at the very beginning from Dr. Cummings. Wow, I'm glad you're here. One of the inhalers you're using is killing you. That is a fantastic technique. Oh my God, which one? Let's stop using it. Your cigarettes. The little fear aspect there certainly gets someone's attention, but can you scare someone into quitting? Can you guilt them or shame them into quitting? I don't think that's necessarily going to be the straight path to finding out a successful outcome. So let's turn to behavioral health. And so we're going to speak next with Laura Fisk, who is going to enlighten us a little bit more on the behavioral health aspects of how to improve conditions for people suffering from COPD. Please give Laura a huge welcome.
Thank you. It's so great to be here with all of you. So I'm Laura Fisk. I'm the Behavioral Health Innovation Specialist here at CareOregon, and I'm also a clinical psychologist by training. So really wanting to talk with all of you about how you can use specifically your behavioral health providers that or clinicians that are in clinic with you to support the treatment and the work of your patients with COPD. So real quick, just by a show of hands, how many of you have a behavioral health clinician that's in your clinic or that works alongside with you? Oh, excellent, excellent, great. Okay, and then how many of you who did raise your hand tend to be part of the workflow or natural pull-in to pull the BHC to work with an individual with COPD? Okay, so a few. So hopefully by the end of my 20-30 minutes, all of your BHCs will have kind of a new workflow or can get more business for them as well. So just for kind of quick level setting, I won't spend too much because it sounds like majority of individuals in here are familiar with BHCs, kind of who I'm talking about, because the care of behavioral health integration, or the continuum of integration, behavioral health integration is pretty wide. And so really wanting to speak to the individuals who are part of the medical team. So they're embedded, working alongside with the PCPs, with the RNs, with the care managers, and doing team-based primary care approach to managing behavioral health problems and biopsychosocially influenced health conditions. And so it's really easy when we think of behavioral health to kind of lock them in with mental health conditions, but absolutely they can support individuals that also have some of these physical health conditions and the complications that come with it. So I always like to highlight this last paragraph where it talks about how a BHC can work as a generalist, and they provide services at a high volume, so alongside with primary care that's accessible, team-based, and a routine part of primary care. So they can assist in the care of patients of any age and any health condition, including COPD. So why involve BHCs? Well, I mean, we've heard a lot already, I feel like, in this morning, that I've been able to pull out some pieces I hope to remember to kind of bring in as I talk, to connect some links of when you could bring in a BHC. But definitely because we know advanced stages of COPD, individuals have that decrease in quality of life and decrease in functioning. And so it affects all areas of kind of their day-to-day life. So if it's work, or if it's family, if it's just activity, things that they enjoy. So there's huge implications, especially as this disease progresses, and so BHCs can come in and provide some support there. And that's including those identifiable health behaviors. And then smoking. I feel like I really should bold this one because smoking is one of those main areas, as it was talked about before, about the behavioral and then also the physiological components with smoking that BHCs can really help with and assist with the smoking cessation. And then we also know depression and anxiety complicates COPD. And so when someone is coming in and also presenting not only COPD, but then also having an added layer of depression and anxiety, that is another reason to involve your behavioral health clinicians. And this list is definitely not exhaustive, and I'll talk about kind of other ways as well. So when to bring in your behavioral health clinician. So top one, of course, when they're a current smoker and ready to quit. Right, so we really want to kind of strike when the iron's hot, and so when someone comes in and that they're finally at that place where they feel that they're ready to quit, we want to surround them as much as possible with the various clinicians and the team members who can help support that. And I will say that if they're not ready to quit, it's still also a reason to bring in your BHC to help with some of that motivational interviewing. So someone who's more in that pre-contemplation, contemplation stage of change, BHCs can help them kind of weigh those pros and cons. Should we quit? Should I not quit? Kind of understand the values, what would be important on the other side if they did quit. And of course, there's always those people who are like the pre-contemplation, right, who have like look at you funny if you even kind of mention the idea of quitting, where that's they're so far from it. But even those still is just another member to help invite that conversation. Also, individuals who with COPD who are struggling with that medical adherence. So we've talked a lot about as far as being able to take their medication, do their inhalers on time, or as prescribed. And so what we find is that individuals come in and they have these various barriers that are preventing them to follow through with their treatment plan. And so BHCs can come in and really help assess some of those barriers and understand kind of what is preventing them to be able to follow through with the care that they're expected or that we know would be helpful for them. And really being able to take, I want to go to the second bullet point, this trauma-informed care approach. So really being able to kind of assess, like, what does this individual need to feel safe in order to be able to feel that they can engage and engage well in their treatment plan. And so BHCs very much can equip to do that. And so not wanting to assume too much about knowledge of trauma-informed approach, but this comes a lot from the ACEs study that was done back in the 90s, and so the adverse childhood experiences. Is this familiar to individuals in the room? Okay. So one graph that I wish I actually had pulled out and put in this presentation is that they found that individuals with a score or a 4 or higher have an increase, have a 390% increased risk of developing a chronic pulmonary disease, including the COPD. So I don't know the research on how many now of individuals diagnosed with COPD also then have trauma, but I assume that it's probably also highly correlated. So we can expect that many of the patients that we are working with COPD have some sort of significant trauma in their background, or as well as even current events going on. And so even another reason kind of pull in your BHC as that added layer of support and kind of team member to help them figure out how they can feel successful in carrying out with their treatment. Also, as far as when to bring in BHC, struggling, of course, with depression and anxiety, and I have another slide that talks a little bit more about this and distinguishing between what is a presentation of the kind of disease versus what is an actual diagnosis of depression and anxiety. And then, of course, that support for health behavior change. So we know when it's scary to exercise because of that shortness of breath. So it's hard when we say to go do that exercise program, that feels okay. So BHC can help do some of that bridging to kind of what this can mean and look like for me, and helping to build some of that self-efficacy and engaging in certain health behaviors. And also, I will add into eating. So eating gets more difficult with the less breath that we can take in, and so that they can also help with some of these strategies. And I'll talk a little bit more also about the interventions, but these are just kind of highlight what are kind of flags for you to know of when to pull in the BHC. And then with that, the support of health behavior change is motivational interviewing. So majority of BHCs are very well trained in providing MI and helping individuals get to that place where they feel like they have the confidence to engage in these health behaviors. Increased social support, so we know that if we can't do these activities we previously could do, we have trouble keeping up with our families and friends, we're more likely to be socially isolated, and which can have a negative impact not only on our health condition, but then it adds that layer of depression. It also adds a layer of anxiety of not feeling that you're connected with others. And so BHCs can help support some of that social support and help be able to pull individuals in so that they do feel like they have a true team inside the clinic and then also outside in the community. And then, of course, skill building. So this could be around sleep, insomnia, skills for exercise, eating, kind of whatever other behavioral health, behavioral-based skills would be helpful. So then also coordination of care. So I had mentioned the trauma piece, and that can be pretty significant for some individuals as that comes up in maybe some of the work or the assessment either by you as one of the care team providers or by the BHCs, that they can support being some of that bridge and getting them into specialty behavioral health care in order for them to be able to work through a little bit more of whatever whatever previous events or current events are impacting them. And so the BHC really can be either that bridge or help with some of that coordination and care. So depression and anxiety. So research we find, and I was actually surprised, I thought these numbers were a little low for what we can see with COPD, but there's a prevalence rate of 40% depression and COPD in older adults, and then 36% prevalence rate of anxiety with COPD in older adults. And really we find that, as I mentioned earlier, that with this, with the difficulty in engaging in activities that do cause for kind of that physical action, that it is harder to want to continue to do that, and it makes sense that individuals would start to feel kind of more lonely, have the decreased functioning, the loss of roles, that decreased self-efficacy, and that we would assume that depression is very common and a very would be not surprising diagnosis to also see being presented. It can get a little tricky though when we see when individuals come in and they present fatigue, they present difficulty sleeping, they're having trouble getting out of the chair, whatever it might be, that it can be difficult to distinguish, is this actually just the COPD and symptoms of the diagnoses, or is this a true diagnosis of depression? And that's where the BHC can really come in and assess, kind of understand more what are the cognitive factors that are also at play when this individual is experiencing the symptoms, and really be able to tease out, is this more of a diagnosis of depression, or is this more, feels more kind of just correlated with the COPD. And then, of course, assessing for the smoking cessation. So we know that individuals who receive assistance from 2 or more types of clinicians are twice as likely to be successful in quitting. And we know that it does take multiple attempts to quit in order to successfully quit. And when working with patients, I've been very transparent with that, and not to give them kind of false hope, but to let them know that it's okay if this isn't the time that they actually quit, that it does take multiple attempts. And I've read up to 30 attempts in order to actually be able, or to be successful in quitting. And I think the average, it's somewhere between 7 and 14, I want to say. I try to find it earlier. And then if the individual is referred, chances are the BHC will really want to work on the smoking cessation with the individual. Of course, we would want to kind of have treatment adherence to what they're most engaged about, what the patient is most engaged about, but knowing that as long as the individual continues to smoke, it is difficult to make other changes, or for the patient to feel successful in these other changes as they continue to smoke, just knowing the effects of it. And I wanted to mention, I appreciate Heather saying as far as the guilt piece, and this I think also correlates well with being trauma informed, that if patients, we're very good at carrying our own guilt and our own shame without even having others kind of say anything to us of what we feel like we should do, or we know that we should do, and that it's very easy to kind of develop or to exacerbate some of this own guilt that we're experiencing. And so really around the smoking, of having a very open conversation, trying to create a safe space, to just asking the patient, are you interested in talking about smoking today, can be very helpful and remove some of that shame from patients when trying to introduce even the idea of quitting smoking. So I wanted to talk also a little bit about tips for introducing BHCs, because this can really kind of make or break the BHC being able to work with the patient. And part of that is because COPD is seen as a very physical condition, and so when you're bringing in the psychologist or the social worker to work with them, that depending on what the individual has experienced in the past, it can be very kind of off-putting, or they feel they can even be triggered by that depending on who they worked with before. So I always encourage care team members, providers, to kind of leave out the credentials at first when wanting to bring the BHC in. So say our BHC is Joe. So this is Joe. He is an expert in smoking cessation. So I would like for you just to meet him at the end of our visit. I don't need to say that Joe's a social worker or Joe's a psychologist, but just to let him know that this is a specific area that Joe works in, part of our care team, and he is specifically coming in to help you with this. And that can feel a lot safer, can feel a lot more structure for patients who do have hesitancy when working with behavioral health. And then some other examples. So I would like for you to meet Joe. He's a member of our team who can help you learn strategies to deal with your anxiety. And of course, when Joe does come in, that he would then introduce himself that, hi, name's Joe, I'm also a psychologist, or I'm also a social worker. But allow for him to at least get in, let him know, like, this is the area. We're not going to dive deep into kind of all these other issues, that it's really short term, and it is very episode specific, symptom specific. And of course, other things come up, and it's very natural to continue to work with the individual once that rapport is developed or they find that it's helpful, but really wanting to set that structure for the patient to help them feel safe in meeting with the behavioral health provider. And then the last example, at the end of our visit, I would like to go get Joe. They sometimes work with our patients to help build social supports. Any questions? We have questions at the end, but I might just pause as going through. Yes?
It's just a comment. I just want to say I appreciate this approach. I often will bring this topic up with somebody who's interested in quitting smoking, and I'll say, you know, habit change is really hard, and because habit change is really hard, this is one of the hardest habits to change. We actually have a whole other person who has a lot of expertise in habit change, and I found that people rarely say no when you say it that way.
That's great. That's excellent.
At least you get your foot in the door, because you're right, a lot of patients really don't want to have somebody who's introduced as a psychologist or a counselor or something like that. So I appreciate that point.
Yeah, and that's a great example to even pull up, because we could use that in a lot of different areas, so thank you for saying that. Yeah, when I was working in clinics, behaviorist is a term, and I think it's still used in some other places, and I remember one patient told me as the provider was introducing me and said, oh, this is our behaviorist on the staff, and what's wrong with my behavior, right? And it was completely like, door shut, and it's like, whoa. So it's, it's very, it can be very helpful and just helping the patient feel supported too in how we introduce the BHCs. So I wanted to, in the last few minutes, talk a little bit as far as what different interventions, so what happens when the BHC goes in there, and additionally how they can support. So with the exercise training, sorry, I feel like I'm blocking probably you over there. I want to clarify this, that the pulmonary rehab is definitely kind of where exercise training happens. BHCs can support how do we implement that day to day for you. So we are not the ones to actually put the exercise training in place, to develop the exercise plan for the individual, but we can figure out, like, when is this going to work for the individual, what are the barriers in keeping them from following through with it, and what kind of accountability do they need to feel successful. And that all can really fall on the BHC to help support that, and especially as they're transferred back from pulmonary rehab back into the PCP office. And then, of course, relaxation training. So it's a natural response of when we're shortness of breath to also have anxiety and to have a panic attack and to have that fear and that the feeling that you're going to die. And so, which we know makes the shortness of breath even worse. And so really having the BHC work with that individual to learn these relaxation strategies, learning the different breathing techniques in order for them to be able, in a way, self-soothe and calm down, even when they're starting to have some of the shortness of breath. And of course, CBT, so as individuals are presenting with depression, with anxiety, we can work with them on some of kind of the cognitive emotional overlay that can contribute and increase the symptoms that they're experiencing. And then, of course, the adherence to medical recommendation, and this ties back in with that trauma informed approach. So really, again, being able to identify what are the reasons that this individual is unable to take their medications, or what are the barriers to them actually follow through with the exercise training program. And so really understanding a little bit more of kind of what is keeping them from engaging in what we know would be most helpful for them. And BHCs can do that in a very kind of safe environment. So the anxiety dyspnea cycle is also kind of tied with that relaxation training. So I'll just show you really quick that this is a nice little example of what can happen with individuals, which is probably very familiar with those of you working with COPD. So we get that shortness of breath, and then we start to get this worry. The worry leads to anxiety and panic about how they're not going to be able to catch their breath, they're not going to be able to breathe. Then they increase their breathing rate, right, which makes it less effective, makes it worse, right, and increases that shortness of breath. And so we just enter this cycle. And so BHCs can come in and really help to intervene and help them to know, or to help the patient learn what are the various strategies in order so that they don't have to go through this whole cycle, that they can begin to calm down their breathing, to feel like they can get a little bit more air problem solved in what they need to do, whether if it's getting their inhaler. I mean, many of you know better kind of what those treatment options are, but then to set a plan of when they're experiencing this. And then of course tobacco cessation. Again, I feel like that should be the first and the most bolded, because we know that's what can be the most helpful for individuals with COPD. And then staying again as far as the trauma-informed approach. So I think I have about 5 minutes. If there are any questions around kind of behavioral health, how to use your BHC.
I have more of a comment, but when you did the shortness of breath cycle and the anxiety, we had an experience where we had a member who also had a lot of mental health issues and panic attacks and some paranoia, and would and also some lung issues. Kept going, kept thinking, I can't breathe, and would go to the emergency room over and over and over. They'd get there, his oxygen was fine. We finally, I think we needed to get a pre-auth, but got a pulse oximeter for relatively little expense, and would teach him that, yes, it feels like you can't breathe, but check and look at the number. And if it's low, then we're not saying don't go. If you aren't getting enough oxygen, go to the emergency room. But if you are, then that helped him learn the other ways to get back to feeling also that he was getting enough.
That's excellent, that biofeedback, so that they know and can check in, like, yeah, it feels serious, but how serious is it really? That's great.
My question is about access to behavioral health care providers, and not just buy-in by primary care, but specifically with CareOregon, is this something that a patient can only access through their PCP?
No, so in many clinics within CareOregon, we do have behavioral health providers embedded in their clinic who absolutely can be kind of that front door in order to accessing behavioral health. And so they may start working with the patient and to identify, is this something that we can treat in primary care? And usually it's brief intervention, it's for a shorter time, 20 to 30 minutes is usually when they meet with the patients. And then if they decide that this individual could go for kind of longer, deeper kind of work, then they can help refer them on to specialty behavioral health. Did that help answer your question, or?
Yes, but let me add, I can project, it's okay, you have to run. If you don't have that person in the clinic,
Do you need a PCP referral to get to that person? And do the PCPs, what's the level of buy-in they have? How far have we come from, well, we've got a pill for that, just use your inhaler, or, very strict allopathy?
Yeah, so so first, they absolutely do not need a referral in order, either to see the provider at the clinic. So how CareOregon works is, and I think in some clinics that they need to be assigned to that clinic or be a member of the clinic to see someone. But even then, I think in emergency situations that we have individuals that can be seen. And as far as, I mean, I could actually turn it over to the providers in the room. That I feel many of the providers that I've worked with are very supportive of behavioral health and pulling their patients, or pulling behavioral health in to work with the patients, and understanding that it really does take that team approach in doing that. And then, of course, there's also specialty behavioral health around in the area, and of course, those on Medicaid do have access to that as well.
All right, folks, we have one more segment that we're going to provide for you here. Let's give a big round of applause, please, to Laura. It's great perspective.